Indirect threat care, or care in the warm zone. Once you and the casualty are behind cover, you transition to the warm zone. This is defined as any area where there is still potential for threat, but it is not direct and immediate. We refer to care in the warm zone as indirect threat care. Again, in this phase, you are no longer under effective hostile fire or any other direct threat. However, you are still in a fluid tactical situation. So as you treat the injured officer, work quickly but smoothly, and be prepared to move the patient at any time if the tactical situation changes and the threat becomes direct and immediate again. In indirect threat care, you will have very limited medical equipment and resources. Essentially, you will only have yourself and the contents of your and the injured officer's trauma kit. The priority in the indirect threat care phase is to rapidly identify and stabilize the immediately life-threatening injuries and continue the evacuation to care. Action priority items for indirect threat care: activate medical resources, perform the SCAB-E exam, recheck for additional wounds, and position and prepare the patient for final evacuation to care. Step 1, activate available medical resources. Medic up. As you move into the indirect threat care phase, get EMS resources moving to you. Although with TECC, you will be able to stabilize the preventable causes of death, the medics bring additional medical equipment and knowledge, and most importantly, can get the patient to definitive care. Next item, perform the SCAB-E exam. The SCAB-E exam is the rapid assessment of the patient, looking for the 3 causes of preventable battlefield deaths: bleeding from an extremity wound, airway obstruction, and open tension pneumothorax. SCAB-E is the mnemonic to remind you of the order in which you go through the exam: situation, circulation, airway, breathing, evacuation. If you have any prior first aid or medical training, you may question why TECC doctrine emphasizes that circulation is to be addressed before airway. Good question. Remember, TECC is the right thing at the right time. Think back to the data presented earlier. The most common combat injury, more than 1 out of every 2 wounds, is an extremity injury. And the largest percentage of preventable deaths is from bleeding from an extremity wound. So, we first concentrate on the most likely injury and the most likely preventable cause of death. Also, it takes approximately 3 minutes to go into irreversible shock when bleeding from a femoral artery wound, while you can survive up to 4 to 5 minutes with airway compromise. So, if you are spending time on the airway while the patient is bleeding from a large artery, they will die from that uncontrolled bleeding while you are trying to fix the airway. This is an example of an officer blowout trauma kit, similar to the one that you will be issued. It contains all the equipment you need to treat yourself or another injured officer using the principles of TECC. Included in this kit is the MET tourniquet, which we've already discussed, an H-type pressure bandage, hemostatic gauze, a nasal airway, a chest seal kit, wound pack, an ACE wrap, duct tape because it can be used for anything, gloves, and shears to help you open the packaging. And it all fits into this attractive pouch. Quite the fashion statement. Back to the SCAB-E exam. S stands for situation, meaning always maintain situational and tactical awareness, even while treating the injured officer. Remember that the tactical situation remains fluid, and although you are in the warm zone without a direct and immediate threat, the tactical situation can rapidly change back to a hot zone. Be prepared to switch back to direct threat care and rapidly evacuate that patient to another area of cover if needed. Always maintain radio communication. As a rule, you should use the injured officer's trauma blowout kit for treatment instead of your own. Save yours to treat yourself if you are injured. And maintain awareness for other risks in the area, such as secondary devices. All law enforcement casualties who have been injured should have their weapons made safe once the threat is neutralized or if they have altered mental status for any reason. You all spend a lot of time training on weapons retention and self-defense. An injured and confused officer may perceive your efforts to assist him or her as a threat and could potentially use that weapon mistakenly against you. Get control of the weapon as one of the first things you do in this phase of care. C stands for circulation. Continue to focus on addressing and controlling any life-threatening or massive bleeding. Recheck any tourniquet that was placed during direct threat care to make sure it was not dislodged during the evacuation to the warm zone. And recheck the patient for any massive bleeding that was not already recognized or addressed. During indirect threat care, because the threat is not immediate, you have additional options to treat bleeding. You can use a tourniquet, wound packing with a mechanical pressure dressing, or a hemostatic agent. The pressure dressing is very effective in controlling bleeding, but takes longer than a tourniquet to apply, so should only be used during indirect threat care, not direct threat. Options for bleeding control during indirect threat care include the MET tourniquet. This was fully discussed during the direct care phase. To re-emphasize, it is fast, it is effective in controlling bleeding, and it is safe if removed in a timely manner, which can be done by most of the medics. Apply a tourniquet for any partial or total amputation, even if it is not actively bleeding. The injured arteries and veins often spasm immediately after amputation. Thus, there is minimal initial bleeding, which then becomes massive and life-threatening as the vessels relax. In this phase, you can apply the tourniquet high and above the clothes, or, if you are able, cut the clothes away to expose the entire limb and apply the tourniquet 2 to 3 inches above the highest wound, directly to the skin. If any doubt exists whether or not you should use a tourniquet, use one. Any tourniquet placed during the direct threat phase should be closely reassessed. If it is ineffective or if you can still feel a pulse below it, either tighten the existing tourniquet further, expose the wound and apply a new tourniquet 2 to 3 inches above it, or just apply a second tourniquet immediately next to the first one and fully tighten it. The mechanical pressure bandage is another option for control of massive bleeding during indirect threat care. Again, it takes longer to apply, approximately 2 to 3 minutes compared to the 15 to 30 seconds for the tourniquet, so it is not an option in direct threat. The pressure bandage uses a mechanical advantage to apply direct pressure directly to a wound to stop bleeding. All pressure bandages combine some sort of large absorbent dressing, an elastic bandage, and a metal, ceramic, or plastic device to apply pressure into the wound. The pressure bandage is very effective on extremity wounds, but requires wound packing to be effective on deep wounds. More on this in a minute. The pressure dressing in your trauma blowout kit is the H-type pressure dressing, as shown. It is easy to apply and easy to secure. Most importantly, unlike other commercial pressure bandages, the ceramic H is well secured to the absorbent dressing, so it can be used to fulcrum pressure into the wound. Looking at the H-type pressure bandage, you can see the large absorbent gauze, the ceramic H, and the elastic bandage. To place the H, you must first pack the wound with gauze. Place the H over the top of the packing material. Secure the Velcro on the back side of the dressing. Use a wrap first, cross below the H, and then above the H to create a wide base of pressure and to help hold the bandage in place. Hook the bandage around one side of the H and reverse directions on the bandage, pulling tight to the desired pressure. Then hook the bandage on the other side of the H and reverse directions again, pulling tight to the desired pressure. Continue wrapping the bandage over top of the H, adjusting pressure as needed. When coming to the end of the bandage, throw a half hitch before using the Velcro to secure the end. Remember, 2 is 1 and 1 is none. With all of these bandages, we want to make sure they are well secured so they do not inadvertently come undone during movement or other care. For the pressure dressing to be effective on a deep wound, you must place wound packing into the wound before putting on the pressure dressing. Without wound pack, the pressure exerted on the wound by the dressing will only be at the skin. However, if you pack the wound with gauze first, the pressure dressing exerts pressure onto the gauze, which is then pushed into the wound, placing pressure deep down where the bleeding blood vessels lie. You are given compressed gauze rolls in your trauma blowout kit for wound packing. It's not rocket science. Just unroll the gauze and use your hands to pack it into the wound, filling the wound with gauze. Then place the pressure dressing directly on top of the packed wound. Here are some of the mistakes reported from the front lines regarding pressure bandages. The most common failure reported was that the deep wound was not completely packed with gauze prior to applying the pressure bandage. Remember, in a deep wound, the bleeding is coming from vessels injured deep under the skin. If you do not fully pack the wound, pressure from the pressure bandage will be at the skin level, not translated deep down into the wound. Ineffective application of the dressing was common. You must place the dressing correctly for it to work. Keep the ACE wrap from becoming like a rope during application. The ACE wrap should lay flat as seen. The last common mistake was failure to recheck the dressing after movement of the casualty. Like a tourniquet, these dressings can become easily dislodged during movement. Always recheck. Continuing on with the management of circulation during the indirect threat care SCAB-E exam. Some wounds are not anatomically amenable to treatment with either tourniquets or pressure dressings. The wound shown is in the area of the carotid artery and jugular vein, both extremely large caliber vessels that will cause bleeding to death in a few minutes. In cases such as this, you can use a hemostatic chemical along with direct pressure to control the bleeding. One of the two critical vascular areas on the body that cannot be addressed with either a tourniquet or a pressure dressing is the femoral triangle on the front of the pelvis next to the groin. As pictured here, the large caliber femoral artery and vein run through this area, and if injured will cause bleeding to death in just a few minutes. This area is too high up in the pelvis to be able to use a tourniquet or a pressure bandage. The other critical vascular area is the anterior triangle of the neck. As shown and discussed earlier, the large caliber carotid artery and jugular vein run through this area. And although I'm sure you all know people on whom you'd like to put a tourniquet around the neck, you can't. Your only option to control bleeding in these critical vascular areas is to combine direct pressure with a hemostatic agent and then apply an appropriate dressing to the area. Unlike the earlier powder forms that are falling out of favor, the third generation hemostatic agents are gauze that have been impregnated with a chemical that initiates and/or accelerates the clotting process in blood. Used properly and in conjunction with direct pressure, it causes the body to clot, essentially sealing the injury to the vessel. Even plain gauze, which is included in your kit, has some blood-stopping properties. You can use this plain gauze as a second line if you run out of the hemostatic agent. The blood stopper gauze is primarily to be used for critical vascular areas of the body where you have no other options to control bleeding. However, it most certainly can be used on any bleeding extremity wound to help control life-threatening bleeding. It must be used properly. Unroll the gauze and pack deeply into the wound, then hold sustained direct pressure to the wound for at least 2 to 3 minutes, sometimes longer. Hypothermic patients naturally have decreased clotting, so these agents may not be as effective in those patients. One point to emphasize, hemostatic gauze is not to be used on wounds to the torso, such as abdominal or chest wounds. It is only to be used on the extremity, pelvis, and neck wounds. Celox gauze is one of the third generation agents that may be included in your kit. It is chitosan-based, a chemical that is derived from shrimp shells. There are several forms of this gauze. Based on the mechanism of action to increase clotting, Celox may work effectively in hypothermic patients and has published evidence that it works on patients taking Coumadin or other blood-thinning agents. Quick Clot Combat Gauze is another third-generation hemostatic agent that may be in your trauma blowout kit. It uses a chemical called kaolin to promote clotting, and unlike earlier versions of this hemostatic agent, is not exothermic, so does not create heat in the wound. This agent is currently the first-line hemostatic agent recommended by SOCOM and the Military Committee on TECC. Moving on in the SCAB-E exam, A is for airway. In the indirect threat care phase, any patient with any altered mental status needs to have an external airway placed, from the officer who is just a bit loopy after injury to the officer who is completely unconscious and unresponsive. The nasopharyngeal airway is the airway of choice in indirect threat care and is included in your trauma blowout kit. It is easily placed, can be used regardless of gag reflex, is unlikely to fall out once placed, and is transiently stimulating to the altered patient. If you get your bell rung by an explosion or just out of it due to your injury, having one of these things shoved up your nose just may wake you up and get your attention. Some of you may have been told in the past not to place a nasal airway on a patient with a facial trauma. The concern with that is minimal at best and can be eliminated with proper placement. If the patient needs the airway, they need the airway, regardless of facial injury. The nasal airway is easily placed as demonstrated. Lubricate it with the water-based lubricant if available. If not, saliva or blood will work fine. Pull up on the nose and place the tube straight back, perpendicular to the ground. Do not direct it upwards into the nose, but go straight back. If you meet resistance, don't force it. Just take it out and try the other side. If the patient gags once it's in place, pull it back a little. Moving on in the SCAB-E exam, B is for breathing. The focus of care for breathing in the indirect threat care phase is on keeping people breathing, not making them breathe. Essentially, the focus is on recognizing open chest wall injuries that would compromise the mechanics of breathing and applying an occlusive dressing to restore the integrity of the chest wall. In the picture, air is moving in and out of the hole in the chest, causing the lung to collapse and the heart to shift over. This compromises both breathing and blood return to the heart. By covering this hole, the chest wall is restored. The lung re-expands and air moves in and out of the trachea once again. An occlusive chest seal applied over a hole quickly restores the integrity of the chest wall and the mechanics of breathing. After a few breaths with the hole covered, the lung will re-expand and blood return to the heart will be restored. The treatment of open chest wounds is very important to address. In one recent study of law enforcement officers killed in action, approximately 70% of those who died within an hour of injury had significant chest wounds. The H&H chest seal kit included in your blowout kit has gauze and 2 occlusive chest seals, one for entry and one for exit. Use the 4x4 gauze to dry the skin around the wound to allow the adhesive to work better, and place the dressing directly over the wound. It's just that easy. During the breathing part of the SCAB-E exam, you must look carefully at the injured officer to identify any wounds on the front or back of the thorax. These wounds may be hard to find and typically do not bleed a lot, so you have to look very carefully. Start under the arms and around the shoulder, as this area is the big exposed weak point in your tactical body armor. Any wound under the thorax, from the belly button to the top of the shoulders, front and back, should be covered with an occlusive dressing. Remember, bullets can and do have weird trajectories, so that wound above the belly button may go directly upwards into the lungs. Place an occlusive dressing on any wound from the belly button to the shoulders. You will not hurt the patient, and you may just prevent death from an open pneumothorax. Apply an occlusive dressing over any chest wound you find, and then constantly reassess the respiratory rate and effort of the injured patient. This diagram shows the mechanism of a tension pneumothorax. Essentially, air can enter the chest cavity but cannot escape. This causes air to build up pressure inside the chest and affect blood flow through the heart. If a patient with a chest wound has difficulty breathing that is getting worse at any time, they are developing a tension pneumothorax and need a medic to decompress their chest with a large needle. This is a true life-threatening emergency that must be treated as quickly as possible. Recognize the problem and get the patient to the medic. You have now addressed the most immediate life-threatening problems. Finish the SCAB-E portion of indirect threat care by quickly and efficiently evacuating the patient to the cold zone. If you cannot immediately evacuate, continue on with the indirect threat care action items where you are. Now that you have finished the scabby management, go back and quickly check for additional wounds that you may have missed. In the heat of the moment, you may have overlooked a subtle injury. Bullet wounds can be hard to find. For example, the wound to President Reagan was so small, was located so high in the underarm, and bled so little that it initially was overlooked by multiple doctors. Go back and do a quick blood sweep. Look head to toe, front and back on the injured officer, looking for missed wounds and/or bleeding, and fix anything you find. Additional wounds found in your reassessment, as well as any heavy but non-life-threatening bleeding that you have not yet addressed, should be treated. For this, wound pack and an ACE wrap are included in your trauma blowout kit. Continuing on with indirect threat care, monitor mental status, treat for shock and hypothermia, and await arrival of medics or evacuation to definitive care. Monitor mental status as described in the first part of the lecture. Use the AVPU scale. Talk to the patient. Tell them things are going to be okay and that you're going to get them to care. Pay attention to their responses as an indication of mental status. If the injured officer's mental status is deteriorating, he or she is dying and needs rapid evacuation to care. Treat for shock and hypothermia while awaiting further evacuation. Keep the patient calm. Cover the patient to keep him as warm as possible, even if it is hot out. Do not worry about overheating. Trauma patients do much worse if they get cold, so do everything you can to keep them warm and covered. Position the patient flat on their back if they are awake, and on their side in the recovery position if they have altered mental status or are unconscious. This is a picture of the recovery position. This is how an altered or unconscious patient should be positioned to keep the airway open. The head is resting on the outstretched arm, and the leg is bent and pulled up to keep the patient in this position. Pay special attention to preventing and/or addressing hypothermia in the injured patient. Casualties with traumatic injury are physiologically less able to maintain normal body temperature, and even small decreases in body temperature will decrease the chance of survival. Techniques to prevent hypothermia include minimizing exposure to the elements as much as possible. Try to avoid placing the casualty directly on the ground. Place them on a blanket or other insulated surface and cover the casualty with anything that will retain heat. In summary, for indirect threat care, activate available medical resources. Control life-threatening bleeding if not already done in direct threat care. Place a nasal airway if the patient is unconscious or has any altered mental status. Check for and seal any chest wounds. Recheck the patient for any wounds that were missed and control any non-life-threatening bleeding. Monitor mental status and treat for shock and hypothermia while awaiting transport to definitive care. Pretty simple, right? Well, that's it. TECC for the downed officer in a nutshell. There's more to come for you in this effort to get all officers trained on these potentially life-saving skills. And of course, you'll be given your individual trauma blowout kit. I appreciate your attention during this video and invite any questions or comments. Just email me at my county email address. Be safe, keep your head down.